Welcome everyone. Thanks for coming tonight. I'm very excited for tonight's presentation. Dr. James Stadler, I hope I'm pronouncing it right. I usually ask before I start. Am I?
Yeah, the only,
Okay.
I actually, just for everybody, just because of the third there, I end up going by Andy for everything, so if I say that.
Andy Stadler. So usually what happens is I'll have the presenter kind of introduce themselves, talk about a bit about why they got interested in Syringomyelia, Chiari, these kinds of disorders, and then I'll let you kind of go ahead and go on with your presentation. And then once you're done, I'll kind of pop back in and we can do the Q&A session. But first, just if you can introduce yourself a little bit, talk about why you're interested in these things, and then you can go ahead and get started. Thank you.
Well, thanks, Caitlin. Certainly, I'm excited to be here too. This is a great opportunity to connect with people who are clearly very involved and have a lot of interest in the field and really are helping advance the whole field from the clinical and research perspective. And really, it's an honor and privilege to be here. My interest in this area stems really from the fact that as a pediatric neurosurgeon, this is something that we see very commonly. It's something that we see that is a challenge, and it's one of the greatest rewards as a physician and especially as a neurosurgeon to be able to help people who have really challenging problems that don't have obvious answers. And that's part of what we'll talk about today is that there's not one clear-cut answer to this. My real perspective on this comes from, I have to give full credit to the people I've worked with along the way. I spent a lot of time in Chicago with the team there and in California with Jerry Grant, I know was, for example, on the board here, and with my current team at the University of Wisconsin, and really I've seen a huge amount of effort from people who are very passionate in this area because it is a huge opportunity to help people with really pretty tough problems that don't have clear answers. What does that lead to? It leads to also an appreciation for why some of this is a challenge, and it's in part, when you look at people who are absolutely outstanding in their field and are really expert with this and have a lot of passion and dedication to try to figure this out, and you realize that these divergent, these different groups and different individuals have different thought processes, you increasingly realize that there's not one right answer here, and that's part of the real challenge that I think we have. And I'll be honest, right before we started this presentation about 10 minutes ago, I changed the subtitle here to learning what we don't know, because it's true. I think that there's just so much of what we don't know, and what I'm attempting to do today is not to get into the fine weeds of the individual strands of knowledge that we have. That's absolutely critical. It's absolutely important, and we'll talk about how that works and how that fits in. But to maybe take a step back and say, how do we think about the broader picture? How do we organize our thoughts so we can be more effective as we're getting those individual pieces of knowledge? So hopefully we'll accomplish some of that. I unfortunately have no conflicts of interest financially. I wish I did. Starting with some basic definitions. What is a syrinx? Of course, we want to talk about what we're all on the same page. I'll tell you that this is in itself already off the rails in terms of being a somewhat difficult slide to be able to say that this is an absolute single definition, and there's a loaded terminology behind all of this. But just broadly speaking, a syrinx is a cystic cavitation within the spinal cord. It's often progressive, and the presentation can vary from being something that's completely asymptomatic or incidentally found to being really very debilitating and causing significant problems with spinal cord dysfunction, of course, pain of a variety of natures, and other problems like scoliosis or systemic problems that we'll talk about. I mentioned a variety of backgrounds. My own background, I do have I spend a lot of time studying classics and focus on this, and this was one of my favorite tidbits that I always throw at my students and residents is where does the word syrinx come from? It actually comes from Greek mythology, from a nymph named Syrinx, who was being chased by Pan, who you see also depicted here. There's an interesting connection between that. This is a painting from the 1700s, a French painter, de Troyes, who painted this depiction of it. It's one of the more colorful depictions of this, where she ran away from Pan. She was a follower of Artemis who was chased and ran away from Pan, trying to avoid that, and ran to the river nymphs, and she was hidden among the reeds, and they actually turned her into the reeds, and he collected those reeds and turned those reeds into his classic pan flute, what we call a pan flute, but has also been referred to as a syrinx in itself. And interestingly, I am still struggling to figure out whether it's completely coincidental or not, but there's probably some note that Pan himself, as we look back at Greek mythology and try to put a historical perspective on this, is interestingly that when you talk about somebody who has a club foot and a fawn's tail and an abnormal gait, might represent somebody with an occult spinal dysraphism too, and whether or not that's actually a connection or not is interesting to ponder late at night, maybe. Broadly speaking, I mentioned that I wanted to take a step back and think about how do we approach a topic, and this is a great book that I think is actually really helpful for not only physicians but certainly for patients too, of how to, in fact, the quote on top here is, must read for every physician who cares for patients and every patient who wishes to get the best care. This is an older book by Jerome Grootman out of Harvard, who talked about how do doctors approach uncertainty, and because all of medicine is really uncertainty, and how do you deal with that? And there's a lot to be said about that. This is part of what we'll talk about. We'll loop back to this maybe in a little bit, but it's a really important thread that is probably more important than any individual fact that I'll tell you about Syringomyelia, is that understanding how we try to approach complex problems logically is incredibly important. And how do we make important decisions with patients of how to figure them out, figure out the problem, figure out what to do about it, and how do we, certainly big decisions like surgery. So an ideal map of that would be that you have a single cause, something that was the root of a problem, and that cause directly caused the problem. It was necessary and sufficient, and in itself just caused the problem. And then that leads to a specific outcome. And that would be a great way to map a disease. If ever the disease has read the textbook, we apply some terminology to the steps in between, so the pathophysiology and the treatment that we might talk about. So in this situation, we might, when we talk about a syrinx and we put that at the center of this equation, we might look at this and say, well, we have a Chiari, and that has a certain pathophysiology, a certain pathway that leads to the syrinx. The syrinx in itself, you might have a treatment for, and that should ideally, in an ideal situation, lead to one set outcome that we could be able to tell patients and their families what to expect specifically from that. Of course, as you know, this is not going to be the case, but we will be looping back to this diagram pretty extensively. So let's start at the left hand of that. Let's kind of dissect this a little bit more. So if we think about what causes a syrinx, well, like I said, of course, we say that Chiari malformations cause a syrinx. I think that is in itself true, but that's not the only cause. And frankly, Chiari malformations, that's a whole package in itself that you could unwrap a lot more. And that also you could take and apply another step to, and extend that diagram even further left and say, well, what causes a Chiari malformation? And that's a whole nother presentation that's way beyond the scope of what I can talk about tonight. And frankly, this group has had really expert people who've talked about all these areas. This is part of what inspired me to take a little bit of a step back, because you've had really great people who talk about some of these areas already, and I think that's important to think about in itself. So you have this group, but you also have other things. You have tethered cord that can cause a syrinx. You have hydrocephalus, trauma, tumor, scarring, and frankly, a lot of syrinxes we don't know what causes them. Again, you can take a step back and dissect any one of these for the even further step down that road. So if we look back at our ideal map, we now transport this into a real world map where even the simple description of saying a Chiari isn't fair. We increasingly think that a Chiari, not just even those breakdowns of Chiari 1, 1.5, 2, etc., even beyond that, even within the category of a Chiari 1, for example, we are increasingly trying to parse out, well, which of those is caused by a developmental mismatch between the bone and the neural elements, which of those is caused by cranial-cervical instability or from connective tissue disorders, which of those is caused because of hydrocephalus, secondary to hydrocephalus, and which is the chicken and the egg there. And that becomes a whole kind of difficult package just in itself. And you could take any one of these little squares and explode that as the diagram. So we're going to see this as more schematically. Next step in the road is the pathophysiology. This is actually a great chance to highlight. In fact, this group had a great talk from Dr. Batsdorf about his work trying to clarify the pathogenesis, what actually causes a syrinx, why do you get a syrinx? And the reality is the very short answer is we don't know. This is discussed and debated for a reason. There are a number of theories for a reason, and the reality is that when you have competing theories like that and none of them are perfectly correct, then it's hard to say that you have any theory. A unified theory would really have to include not only why you get it to start with, but why it responds really well. Why typically we see a good response to posterior fossa decompression. Why you get syrinxes from other causes. A lot of these, for example, I'll focus on the Chiari aspect, but what about subarachnoid scarring? What about a tethered cord? Why would that give you a syrinx? And how does that unify together? And broadly speaking, we talk about changes in cerebrospinal fluid flow dynamics, and I do absolutely think that that's true and important, and not taking away from any of this work, because this is really important work, but it's not really clear right now why we get a syrinx in itself, and that confuses it even more. So when we have this, we start to say, well, there's not one line that leads to a syrinx. There's multiple lines that are coming from different directions and might go in different directions too. So we look, next step in the process is looking at the syrinxes themselves. And this is, you're going to see a common theme emerging here, that this is not well understood. And are all syrinxes the same? Well, of course not. This is very well described. There was a really great paper a few years back by, I believe out of Germany, one of the teams that was, I'd have to get the specific citation, but really tried to break down, the broad scope of this. And actually, in fact, I was in that paper, but also in, I think, one of the better chapters that's been written by one of my partners, Dr. Iskandar, Benny Iskandar, who wrote about, we have this terminology for syringomyelia versus hydromyelia, and then people further break that into syringohydromyelia, and we also have very related terminology related to dilated central canals. And I absolutely think that it's important to parse out and be precise at an individual patient level. This is very important, and I please don't misunderstand what I'm about to say, but at a population level, this becomes tricky, because not every surgeon, not every researcher means the same thing when we're talking about these terms. And that becomes very challenging then to say, to evaluate that and to look into how do we clarify these meanings, and what do we do with this information if when one person says syringomyelia, they're referring specifically to a cystic cavitation that's outside of the central canal, and has a clearly identified cause, for example, as some researchers might apply that, or even size criteria to that, whereas others use terms differently. And this leads us actually to take a little bit of a step backwards so we can look forward by just saying, and you'll note that throughout my talk so far, I've used Syringomyelia as a fairly broad, encompassing umbrella term. And right now, as the state of the field is, I think that that's actually probably more fair than trying to be very specific, because some of the specificity leads to confusion when it's used differently by different people. And I think that that's a real concern that we have within the field, and is something that is actually a good opportunity to try to clarify going forward. Unfortunately, people have tried to do that, but it's trying to get everybody on the same page is sometimes a bit challenging. When we talk about the differences between syrinxes, location is extremely important. This is not only true for what symptoms they're going to cause, which is absolutely the case, but what we think about is the etiology. Where is this? Is this, first of all, is it within the central canal? Is it a dilation of the central canal, or is it adjacent to that? Is it in the upper cervical spine, or is it in the thoracolumbar spine, or someplace, or across the whole spine, or any combination of things? The size of it, and then also the trajectory of that size. So how do we follow along and map this as you go? A small syrinx that stays very small and is essentially a small dilation of the central canal is very different than a holochord syrinx that's shown progression over time. Okay, those are very different medical conditions that have very different implications and urgency to them. And if we know an etiology, that's of course very relevant too. Not always the case, but it adds to the confusion because it separates out different groups within that. So we include a number of groups there, making the map more confusing. And I could have added a near infinite amount of complexity to this. I'll of course keep going. How do you treat a syrinx? Well, it's in general, this is where we talk about, as a broad stroke, we try to identify what's the underlying cause. We try to say, how can we most clearly identify what is driving this, and then reverse that process, whether it's the hydrocephalus, whether it's most commonly a Chiari malformation, whether it's a tethered cord, tethered spinal cord. Less commonly, if I said 5% of the time, we're talking about something that's a tumor, and this is, again, it's back into terminology, where is a tumor, cystic collection around a tumor, is that really a syrinx? I would actually argue that maybe that is an easier one to remove, at least from some of that consideration, especially as we talk about what's driving that, and trying to unify theories with that. We know that if it's producing fluid within a pocket within the spinal cord, that behaves differently. If you have a spinal cord injury or bleeding that has caused a lot of adhesions, and you can do a lysis of adhesions, that might be a good option for some patients. And I'll say decreasingly, it's still listed in a lot of algorithms, but decreasingly we do use syrinx shunts, subarachnoid or syringopleural shunts, for example. I think that that's, at least with the teams that I've worked with across the board and in my own practice, certainly is less favored as a first choice, but it's certainly a good option for appropriately selected patients. In general, though, we work really hard to identify what's that underlying cause, so we can adequately treat that as a first step. People have attempted to map this out, and this is a slide that in part just shows that, even focused on somebody who has a clearly defined syrinx associated with a Chiari 1 malformation, the map gets pretty complex pretty quickly. We'll go over some of the other algorithms. This is not the end-all be-all, and I will tell you that even, frankly, this is in a chapter by, again, one of my partners, Benny Iskandar. great chapter and very thoughtfully written. And I will tell you that even within our team's practice, we aren't married to this algorithm. This is not something that's an absolute for every patient, for every presentation. And I think that this gives a common, people, the value of this is to provide some common ground to have a discussion, to start a discussion on, and organize your thoughts for, and provide at least some reasonable course of action. But it has to be very individualized to the patient, and as a conversation with them, and what their issues are, and how we think a little bit more broadly about this. Similarly, we could go through algorithms for a syrinx that's associated with spina bifida, or essentially with a Chiari 2 malformation, and you can have a separate consideration with that. So this is starting to parse this out and add depth to some of those decisions that we have. Idiopathic syrinxes, I will say that I noticed that we had already gotten a couple questions about idiopathic syrinxes, and I'll try to answer some of that here. This is one thought process here. This is another area this is a really good example, actually more so maybe, that of talking about how terminology affects your thinking. If you refer to something as a small idiopathic syrinx versus a dilated central canal, this becomes a somewhat relevant distinction here. There's a lot of work, and for example, when dilated central canals were first described, or probably best described maybe by Dr. Holly and Dr. Batsdorf almost 20 years ago. This was a little bit of, they treated those as a little bit separate. Even within that study, there's probably some crossover with how we would currently define some of those patients. And it becomes the terminology. This is a good example of where terminology becomes very important to be able to parse out how do we think about something, and where do we take that information. Again, not being married to any of this, this is relevant, and this is another good opportunity to highlight the Chiari 0. We'll talk a little bit about how do we evaluate for these things too. So as we go, it gets more and more complex. This is a simple slide that, yes, it absolutely gets very confusing. And it only gets worse the more you dig in. So each of these then is associated with certain probabilities. The outcomes are never black or white or a single set outcome. It's of course a gradient. It's a spectrum that we think about in terms of function along multiple axes, along your function, along pain, along a scoliosis curve. And then time is a huge factor here, that there's an additional dimension with that over time, and how does that impact things, and how does time get reflected even in the studies that we have or don't have, is very important. So that leaves us with a little bit of a mess, and certainly a moving target. This is very complex. Maybe the lightheartedest picture I could put for a situation that's a little bit of a mess to try to sort out. But it still leaves us with a lot of optimism for an individual patient, because what we're talking about mostly is at a population level. For individuals, we're increasingly getting more and more clarity of how can we navigate through this. But it is tough, because there's not one map for the whole that applies to the whole group. This is a slide that I'm not sure how to introduce, because it goes in a couple different directions. If nothing else, it's a good book recommendation. Nate Silver's book about the signal and the noise, about how to sort through statistics and statistical thinking, is something that I've personally found very insightful. The person next to him is not Nate Silver here. That's actually Thomas Bayes. And I think, interestingly, he's probably one of the most influential, important people for medicine, even though he was not in any way a physician or did any work in medicine directly. He was actually a mathematician who focused on probabilistic thinking and probability theories, and how to take information and based on new information as you're getting that, how does that influence based on your pre-existing information that you already have. And essentially this is his formula, Bayes' theorem about for the probability of A given B is related to the pre-existent probability of B, and then you associate that with how likely those things were separately and independently. And this is another way of saying that. Actually, the quote here on top from Warren Buffett is that how do you make decisions? Well, it's sometimes that you're taking these probabilities, you're taking these thought processes, and you try to factor in as many meaningful predictors as you can, and you take that and say, well, something's super likely and it has big impact. How does that influence something that's less likely, less impact, and how do you make decisions between things and weighing these things? And this has to be intuitive. There's not a number that you put on paper. I don't sit in clinic with a calculator. This is something that we have to mentally process, and honestly I think it's one of the tougher skills in medicine is to be able to think probabilistically of how do you sort through and decide even simple things like when do we get the next scan, when do we recommend surgery, when do we recommend observation, based on what your thought process is. And we want to be thoughtful as much as possible about that to get to the right answer. So where do we add in? How does this? How do we move forward? So that leaves us with a bit of a mess. And I'll go quickly into some literature here. I don't want to get hung up on very specifics here, but this is where it becomes incredibly helpful to have very good, smart people trying to answer and map out some of these very specific segments of that area. So when we've taken a step backwards. Now, if we zoom in and look at, for example, the Park-Reeves work that's been done, and how does this focus on very specific questions? What is the relationship between this factor and this factor? Trying to map that out. It's not going to provide the whole map, but it provides very specific pathways, ideally the most common and biggest and the most important pathways for patients. But it's something that we can start to see and get more clarity of what's better. For example, in this setting, which is a common scenario, how does that, which is going to be better, the opening the dura or not? If you have a Chiari and a syrinx, which is going to respond better? How does this respond by different ages? How does that change your probabilistic thinking? If you're dealing with somebody who's 4 years old versus somebody who's an adult, those are different populations. We know that those are different patients, and how can we actually start to dig in and get real answers to these questions? We don't have all these answers yet, and that's only fair for us all to acknowledge and be very clear about that. None of this is perfect, but we can absolutely get better. And that's the good news, is that there's a lot of opportunity. We've gotten hugely better along as we've gone, but I meant to point out at the very beginning of the talk, that when we look backwards historically at syrinxes, these were first described in 19th century. Up until even the 1970s, these were considered to be a progressive neurodegenerative disorder, and that didn't have any treatment for it. We've made huge steps already. How do we get even better as we go? This is going to be one of the answers to that, is answering very specific questions through clinical trials, trying to address the biggest and most urgent populations first. Part of that's going to come as we can better stratify patients so that we can understand what's driving this and can be more clear about what we're actually answering when we look at these populations. Of course, technologies and being able to say more clearly what the problem is going to be helpful. That's better information is always helpful to help clarify those pathways. And sometimes it also is relevant to take a step backwards and look at the bigger picture at the population level, big data. And I think that, frankly, this will be something that has huge implications, that artificial intelligence is going to be able to really help us see patterns that we might not appreciate right now, whether it's with certain radiographic parameters or clinical areas that might help us and give us insights. It's never going to fully replace things, not in the foreseeable future, but it's not going to replace clinical judgment in that conversation. But it's really important to sometimes help identify patterns that we don't appreciate right now. Ultimately, the more we can understand things like the genome and epigenome, and being able to be more clear about what we're doing for the individual is obviously important as well. So I fully recognize that I haven't given huge new specific information about syrinxes. For what it's worth, whoever on their bingo card for tonight had a French painter and Nate Silver and some statistics formulas probably would win their bingo tonight. But the reality is this is too complex to be able to say that we're going to have one answer to be able to map things out. We absolutely want to leave some time for questions. I'm going to pause there for my slides there and jump towards the questions though then. So Caitlin, I know that you've been looking at the questions that were already submitted and also what's coming through now.
Yeah, thank you. I've first of all, thanks for the book recommendations. I'm definitely going to read those. And then we did have some questions that came in ahead of time. Some of them are sort of definitional, so I kind of want to start with those. But there are some really good questions that are coming in the chat, and you can keep sending them in. I'm going to bring those up as well. So you kind of talked about this, but you didn't explain how it's done. So is there a specific way that experts differentiate between the hydromyelia, the slit-like syrinx, or prominent central canal? Like, I know the terminology is just the terminology, but I guess what's the thought process behind each of those terms?
Yeah, absolutely. No, thank you for helping clarify that. This is important. As we're sorting some of these things out, it's a syrinx, as I use it, tends to be a broad umbrella term. When we talk about as at a population as a group level, okay. For an individual patient, this is very, I think, important for us to dig into and be very precise and as precise as possible about what specifically we're seeing. This is, and so I think you can use actually both of those at the same time, talking by separating out, by talking about it as a group versus as an individual. For an individual, how do we clarify what that looks like and try to be precise about that? The main first difference is going to be where we feel where, based on the imaging, that's actually located within the spinal cord. Okay, so some authors and researchers will parse out a syringomyelia in terms of saying that has to be confined just to the parenchyma, the actual tissue of the spinal cord, and that's not how most people use that. If that's, I would say, in day-to-day life, most people use it that as certainly a syrinx, but also refer to syrinxes otherwise larger too, in part because sometimes that is a bit tricky to tease out. They do often communicate and with the central canal, and that's where the syringohydromyelia comes in. Hydromyelia, if you're using that term, tends to be very specific to somebody referring to just the central canal. I don't think anybody refers to hydromyelia when it's actually a syrinx. People will use syrinx when it's technically falls under what some people would be parse out as hydromyelia. Because of that, it becomes very problematic to try to apply these terms at a population level because it is confused already. And if not everybody's using the same words to mean the same thing, you kind of already have to throw out that concept when you're talking across a group. Okay, especially when you're talking across research studies. Within an individual researcher, researcher's work, you might be able to follow a consistent thread, or if you're very precise about how you're defining that. This is actually in part the moving target that we have too, because as imaging gets better, we will think differently about how to separate those out. Probably the more important distinction that I would offer here now, and probably the lowest hanging fruit to try to separate, if we're going to try to take this group that has multiple small groups within it, if we can try to peel off individually and separate and be very precise about how we're going to think about something, the one that I would try to, and I think that is probably the ripest to try to separate, would be somebody who has a dilated central canal as compared to a small syrinx. And this is difficult in itself. A dilated central canal, some people will have different thresholds for that. They average about 2 millimeters in width, but most authors will include up to about 5 millimeters in the maximum width with that. Is probably most commonly described without a clear cause, without expand, and some people will, and this actually is my own definition too. I do feel that you can't diagnose that at the first image. I think that you do need to show that over time that that's stable and the patient is frankly doing well without symptoms that are felt to be related to that. And this is where I probably am separating. Maybe at least there would be some people who would disagree with that definition, but it's important to be able to say, that for prognostic reasons, most importantly, again, focus on the individual. If you can say that that's a dilated central canal and that it's stable over time and we don't think it's causing you any problems, we do think that those in general then stay stable, although that's a little bit of a self-fulfilling prophecy that if to call it a dilated central canal, it has to be stable. Then to say that central canals are stable is circular. But it's important, and certainly a lot of patients do have that. This is part of why we don't immediately run to operate on small syrinxes if there's unless there's a clear reason for that. Obviously, a small syrinx in somebody who has a Chiari malformation is different than somebody who doesn't, for example. This is also brings us, I know one of the other questions that we had already fielded was about how do we go about evaluating these things. And this is now trying to get a little bit more into the nuts and bolts of things. This is where it's important to, again, try to be very aggressive about getting information. The more information you can get is actually very helpful to help try to understand very precisely where that patient is, and therefore what we can better think about. If we can get some clarity, if we can get some understanding of what's going on, and plot them more precisely on the map, it's going to be easier to find a good path going forward. For our team, and frankly, I think that's something that I advocate for, is somebody who comes in with a small syrinx. I don't think you can just say that a small fluid collection within the spine. Maybe let's back it up even further. I don't think you can say that, so if somebody came to my clinic and had a small fluid collection within their spinal cord, the first things we would do would be to try to be very comprehensive with looking for the cause of that. So we get a total MRI of the total spine and the brain, actually, with detailed imaging, and we do find the flow studies to be very helpful to help clarify that. It's a little bit unclear from the scientific literature of what the significance of that is, but I think, again, at an individual patient level, it can be helpful to understand whether or not that's a contribution to their presentation. Of course, we need to get a good sense talking with the patient and from their exam of whether this is causing problems. I think that that's very relevant, and not not all syrinxes follow the same. Not all syrinxes read the textbook, right? So it's they sometimes cause problems that are very unique or haven't been described before, or they can cause, of course, spinal stereotypic patterns with spinal cord dysfunction, but they might not. And trying to tease out and figure out which of that is related to that or not is incredibly important, so that we can make good decisions going forward. But if we're electing to watch that, assuming we don't identify a cause and we're electing to watch that syrinx, typically then we follow that over time. And I, for example, typically recommend about 6 months that we get another picture for a very shorter interval follow-up to see if it's changing more rapidly. I want to know about that up front. That also gives us a chance to make sure that we're touching base with the patient and that they're doing well. If it's stable over time, then that's where we follow those. And it's only really over time, I think, that you can truly be comfortable with at even an individual level what that's going to mean for that patient. Are they doing well and not having problems and it's stable? Again, that's a very different patient than somebody who's having problems or it's growing over time, or that has an identified cause. Um, uh, I don't know if that answered the question.
No, you did. You actually kind of also are piggybacking into the other question I wanted to ask more definitionally. Um, this kind of came in ahead of time, but I'm sort of reworking it. So, what symptoms are most strongly associated with syrinx? So, does it, and I'm going to say, does it matter where that syrinx is?
Yeah.
Because the diagnosis is sort of, like, as far as treatment is concerned, is based really on symptoms. It's hard to know what symptoms someone should be looking out for if they've been diagnosed, especially with idiopathic syrinx. What should they be looking for?
Yeah, so the easy answer is to say spinal cord dysfunction. The problem with that is obvious, in that the spinal cord is the main communication between the body and the brain, and it really controls everything. Is the highway for all of those processes. So it becomes much more complex. Of course, the location, to answer the easy part of your question, which is does the location matter? Absolutely. So a syrinx that's in the cervical spine, where the communication has to go from the whole body up, is at risk for presenting differently and causing problems in the upper body and even into the face, or extending into the brainstem and causing problems with that. Whereas a syrinx that's in the thoracolumbar spine isn't, by definition, really going to affect the upper body. And frankly, if that patient is having concerns in the upper body, we need to think about that differently. Then we need to figure out, well, why is that the case? And so location definitely matters. Size does matter, but I do see one of the questions in the chat about pain with a small syrinx, and this is incredibly complex because the spinal cord fibers going through there, any disruption to that can cause problems. Okay, it's hard to answer for this specific person, and I wish I had an answer specifically for you. And honestly, I wish I could tell you what the right next steps were for that. But any disruption to those signals can cause problems. Okay, this is to be completely fair to what I was saying before. This is where parsing out central canal versus parenchymal fluid is important. And in fact, this is also goes to the etiology. And I saw that there was another question about beforehand about scoliosis, and we often can see fluid collections and signal changes within the spinal cord that, especially if we go retrospectively back on imaging, might actually be what's called myelomalacia, or spinal cord bruising, that then cavitates. Okay, so an injury to the spinal cord and it cavitates. If you fix what's injuring that, whether that's the scoliosis or degenerative changes or other problems, if you can, assuming it's not, if it's something like a spinal cord injury, that it might not be possible. but you can halt that process. That's going to be different and very specific to that patient. Confusing that even further is that syrinxes can, of course, cause scoliosis, and we do know that that's part of this, that the changes in the muscle tone over time can lead to curvatures in the spine. And that's where it has to be so individualized, and there's not a way around that right now. I wish that there was a way to say, okay, that we have very, very perfect maps for every single presentation and radiographically and clinically, and what that means. But without that being true, we need to just be as thoughtful as we can and make good decisions as we can. For going back to your broader question, what's the symptoms that this can cause? It's so broad. The pain that we do see some patterns. I mentioned scoliosis, that's one. We talked earlier about spinal cord dysfunction, so weakness and progressive loss of motor function distal to the syrinx is one of the hallmarks, if that's something that's is untreated, certainly. And if it's progressive syrinx, we do expect progressive loss of motor function. The sensory loss tends, pain and positional sense tend to be some of the classic. We talk about a cape-like distribution for the cervicothoracic, for especially loss of pain and temperature sensation there, and often we see a dysesthetic pain. It's kind of a neurologic pain that's caused by kind of a painful numbness is what we see. Honestly, I suspect that there's people in this group that are listening tonight that would be able to provide not only a lot more answers, but a lot more descriptions of the symptoms. And I'm not going to pretend to have a perfect painting that shows every presentation with that. This is where we have to put what we see and try to put this all together. Our job is not necessarily to tell what the symptoms are going to be. That's why we talk to the patients. Our job is to try to put together what we're hearing with the patient and what we're seeing on our exams, and putting together with the radiographic studies and what we know about a problem, to try to put that all together and make sense of it all with the patient. That's ultimately our goal. That's every physician's it should be their goal, is to figure out not only that, but then what's the toolbox that you have to try to get that into a better position with the patient, which sounds pie in the skyish. And I wish that I could tell you that was that's a lot easier said than done. Of course, we all live in this perfect harmony where it's everything. But the reality is that should be the goal, is to try to match up with what we're seeing in each of these categories, to understand and everything else diagnostically. And people try other diagnostic tests. Frankly, there's work with motor evoked potentials. There's work with and other neuromonitoring spinal cord techniques. There's work with carbonic anhydrase inhibitors in terms of trying to figure out who's going to respond and things. There's other tools that we can bring to bear on these things, not just the advances in imaging, but more broadly. I love studies like that. Even honestly, if they don't show much, I love that we're trying to think outside the box of what else can we do to figure this, what else can we bring as that might help provide some information here. There's a question about watching an asymptomatic syrinx. That has to be a conversation with your own surgeon. It depends a little bit on when we talk about asymptomatic. This gets a little bit fine-tuned, and there's patients that come to me and they say that they're asymptomatic, and I respectfully sometimes have to disagree as we talk and go through things more carefully, and whether it's a progressive scoliosis or a concern that I see on their exam, or as we're going through symptoms that they might not feel are related, but I think might be. Sometimes, to be completely fair, we don't even know that we're having. Sometimes I've had patients where we do a treatment of some sort and they get better from a symptom that they didn't even know that they had. which is kind of nice, but I'm not going to say is always the case either. The it's hard to understand with the size of the syrinx. It's important. We do think that syrinxes in general, as a general rule, if we have a cause of a syrinx, and that it's especially a larger syrinx, they do tend to show progression over time in general. Okay, that's definitely not the case for everybody. And there are plenty of reports of patients that have been followed over time that have not had any issues with that. And honestly, I think that that's important for us to factor in too. You know, of those multiple arrows that I drew earlier, at least several of those are, maybe we'll just say, representing the option, you know, the treatment option of close observation over time. And that's fair. I think that as long as we are all thoughtful about what we're doing, that should always be on the table, especially individualized when we talk about other things, medical risk factors, what the surgery would include, what the concerns are, etc. Okay, so I think that that's something that we should always needs to be a part of every treatment conversation. Is, you know, what are the alternatives here, and that always includes observation. But it's in general, when we have an identified cause in a larger syrinx, our team, we tend to recommend treatment, and certainly I think it's very reasonable to treat in that setting, but it's also for an individual patient might be very reasonable to be watching that too.
Yeah. To kind of address the other question that came up in the chat, because I think we're kind of talking a little bit about surgery here. A large cervical syrinx that doesn't get better after decompression. So
Yeah.
what would be the next steps for something like that?
So this is, it depends a little bit on what the imaging looks like, and I hate to couch that. I'll give you a direct answer that I would be wanting to make sure that that patient has really, that the decompression was successful, okay? And I think that that is fair to say that, especially if you're having symptoms and there's a concern with that, and certainly if it's progressing in size, that it's typically what I would do in that situation is repeat detailed imaging to make sure that not only the CSF spaces, but also the flow around that area is appropriate, okay? If that has been decompressed appropriately, the next step depends a lot on how somebody's doing clinically. If it's stable and they're clinically doing okay, they're stable, I would personally favor observation at that point. We do see some delayed responses in things. We do see, as long as somebody's not getting worse. The urgency of intervening further is obviously much higher if somebody's getting clinically worse, or is going towards a cliff that we are worried about, meaning that if the syrinx is getting bigger over time, that's a little bit different of a situation. But if it's truly stable and it's well decompressed, then I typically recommend observation. And closer observation. This is where I know one of the questions beforehand was about frequency of imaging, and this is where we do have to, you know, use good judgment and just say, well, what does this mean, right? How big is big? How decompressed is decompressed? And say, well, does that mean 3 or 6 month MRI? Does that mean a year? Does that mean, you know, certainly I wouldn't in this situation go to, you know, 2 or 3 year, you know, beyond a year if we were following something that was still larger. But the first step would be making sure that that's an, you know, appropriate decompression, that you're not, and especially with a little bit more urgency if somebody's having progressive or new symptoms, and then working from there, just being, you know, based on what you're seeing.
Yeah. Something similar had come in prior. So this person said that they had had several syrinxes removed, and I'm not sure if they mean that they had a mass removed and they had several syrinxes within their cord.
Yeah.
But the question really is, it's a good one. So what are the chances of something like the syrinx coming back,
Yeah.
like rearing its head later on, and how long do you follow something like that?
Yeah. The giving you an exact statistic is tough because we don't have those real statistics. That's not able to say. I'd say that in general, once you've appropriately treated that underlying cause, that's overall low. So if somebody has, in general, this also, I agree. I saw that question and I wasn't certain when we talk about it being removed because it's a potential space that you can't really, cut that out. But if it was something that, so let me give a couple scenarios here, maybe a little bit easier. If it's a Chiari malformation and it's gotten better and they're clinically doing well, overall, honestly, after they're healed from that Chiari surgery, I think that potential is overall fairly low. We do still follow patients longitudinally, in part so that we get better information about this, because nobody has that 5 or 10-year map on this. That's part of the pediatric neurosurgery side of things. At least a lot of my mentors, we follow people well into their adulthood. So I think my oldest patient I operated on somebody a couple weeks ago that's well into their 70s, and operated on people in their 90s and stuff like that too. So that's separate. Not for syrinxes. So that's one scenario. If it's a tumor, obviously that's going to be mostly driven by tumor recurrence and their pathology. For scar tissue, this is a little bit trickier, and I'll actually include in this just to show you why I get hesitant about this. For example, we actually have a paper coming out shortly about patients with Noonan syndrome and Chiari malformations, and specifically the subset of patients with Chiari malformations and Syringomyelia within patients that have Noonan syndrome, which is an association. And for those that are unfamiliar with that, that's a genetic disorder that is multi-genetic, but it's based on one of the signaling pathways in the body. So it can cause symptoms throughout the body, but that includes we think is relevant here, bleeding disorders, and that they tend to form a really impressive amount of scar tissue. And honestly, we've had very delayed presentations of syrinx progression in that population, 5, 10, 15, 20 years out. Okay. And some of that could be related to the scar tissue. It could be, whenever you start dealing with scar tissue, honestly, that becomes a little bit trickier because if you do a surgery to take down scar tissue, you did a surgery, so you're probably going to get scar tissue. And so that's great if it's successful, but not something that any of us are going to promise to an individual patient. This is one specific example where, if somebody came in and asked, well, what's the chance of this coming back? And by the way, I have Noonan syndrome, right? Which, typically was one of the first things you say. But that conversation is going to be very different than somebody who is more in the center of that grouping with a fairly textbook Chiari malformation and a syrinx and concern. Somebody who has a tethered a tumor, a scar tissue, a tethered cord is their concern. A complex tethered cord we know can retether in probably around 30%, up to 30% of cases. And what does that mean? And show somebody who has a syrinx, and this is where the terminology, again, not to really beat this, but the terminology with a syrinx, but if that's related to myelomalacia, and frankly, one of the terminologies that I would a population that I would maybe separate out is patients. For example, I take care of a lot of patients with achondroplasia, and they have foramen magnum stenosis, and they have T2 signal change there related to very early bruising at a very early age in their life. And this is that's to say that you have somebody who has a tight foramen magnum, and you have a T2 signal change, and potentially would be called fluid on the imaging. And that's, I think, a very, very different population than the people who are here tonight. that are focused on Chiari, even though that's still a tight frame in Magnum and a syrinx, and that's this gets incredibly nuanced. And if you try to apply some of these terms, this is where studies become very tough, because you say, well, that doesn't really make sense, right? We can't use that result in the same way, and that's why it's really important as we try to clarify this that we be precise as possible.
Oh
Sorry.
my God. I'm getting
Gotcha.
such a headache. This is such
So,
like a monster.
yeah, it is. It's a whole lot, and I don't mean that. I think it's really important to be clear that this shouldn't be a pessimistic talk. I mean it actually quite the opposite. I think that to understand this, we need to all, as we get some clarity, we absolutely do realize that this is a much more complex picture than a single pathway. Okay. And that's the good news, is that we are realizing that this is a much more complex picture than a single pathway. That if somebody comes in and says, hey, I have Ehlers-Danlos and a syrinx, well, we know that there are going to be connections through there, even if they're not following the textbook algorithm of saying, well, this is a set Chiari and blah, 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 and blah, 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 and blah, blah, blah. Somebody says that they have Noonan's, or somebody has any presentation, it's more of a call for us all just to be thoughtful.
Yeah. It's so hard to generalize, but if anything, it's really good, because that means that when a patient walks into a room with their doctor, like, that has to be a very intimate like conversation, because it's so specific. We kind of talked about this, but I did want to ask it more specifically. So here we go again. Do we know if an idiopathic syrinx will progress, and what qualifies as stable? So if there's a little bit of ebb and flow there about how wide it is.
Means it's sometimes, especially as MRIs get better over time, we sometimes get a little bit more detail, and sometimes progression isn't real. Sometimes that's an artifact of time. Okay, but that said, in general, I think I actually mentioned this paper before. The Langston Holly and Dr. Betzdorf wrote a good paper. The first description of this looked at patients that they described as with the small idiopathic syrinxes, and they didn't really progress radiographically. One patient, they had, I think it was 30 some patients, 32 maybe patients, and one of them ended up getting surgery. A good number, actually, I think 7 or 8 got worse clinically though in their study. And these are rough numbers, but trying to ballpark, well, what's your general risk here is that some of those patients did absolutely get worse clinically. Now that study again was about 20 years ago. I think that it's harder as we go to watch somebody get worse clinically. Okay, and this also reflects, again, that's 20 years ago. It's only 50 years ago that this was in a lot of textbooks as like an untreatable, progressive, we're sorry, there's nothing we can do condition. And frankly, that's the great news, is that we're making good progress with this as a field, but it's of understanding how do we do this a lot better. But it's in general, there's a little bit of a circular argument of, how much do you treat something as not a problem because it's showing itself to not be a problem. Okay, so yeah.
We have a couple of questions. So one came in prior and one just came through the chat. So I'm going to separate them out because they're two different things, but it's actually asking about neurologists. So are pressure headaches and burning nerve pain or neuropathic pain a symptom that's generally treated by a neurologist, or is that treated by you all neurosurgeons? And there's specific questions about what medications are available for that. How do you reduce the pressure headaches, and then nerve pain is going to be, I guess, a little bit different.
The question that came in pre asked specifically about Diamox and methazolamide, and both of those are so Diamox is the trade name for acetazolamide, and methazolamide is it's a very similar. It's a little bit more rapid acting, but both of those are carbonic anhydrase inhibitors that what they do is change the physiology of how your cerebrospinal fluid is produced and overall decrease the production of your CSF, meaning that you have less CSF and theoretically less pressure. There actually is an interesting study. It's a relatively pilot study that was out of, I think, North Carolina, that looked at using that to help clarify who was going to get better for patients, especially with an atypical presentation of a Chiari malformation. Somebody who comes in and has a Chiari malformation and maybe has atypical headaches, which of those patients is going to get better? And they found success in using that as a tool for that. So certainly there are some patients that are going to respond to that as a headache treatment, and that's great. And if it's either used as a primary treatment or as essentially a treatment / test to help diagnostically, that's awesome too. And if it provides information, that's cool. And again, I actually really like when people are thinking outside the box of how do we stratify and help understand these populations better. The question of are headaches and the dysesthetic pain treated by a neurologist? Absolutely, most neurologists would be comfortable treating that. That's well within their range of expertise, is helping treat that. Of course, like neurosurgeons, neurologists specialize in different areas, and an individual neurologist might or may not have comfort with that. I personally follow more of a philosophy of trying to bring a lot of people to the table and get a lot of opinions on stuff. And frankly, it doesn't mean that you have to, information is neutral, right? It's, and opinions are actually somewhat neutral. It's what do you do with that matters. So honestly, I encourage patients to work with a wide variety of providers to get as much information and try to help sort this out as possible. So a neurologist is a great part of the team. A pain specialist is often a really great and important part of the team. Frankly, they have a lot of tricks and are advancing their own sciences in really important ways. People, like the rehab teams and therapists, diagnostically, people on that, and we tried, and genetically, and if there's a question of is this under a connective tissue umbrella, right? Sometimes we're lucky here in Madison to have really people who are very, very expert in very niche areas, which is cool. But I say, okay, well, if we're worried that you might have Ehlers-Danlos syndrome, if this is kind of painting a picture that could be concerning for that, I have a world expert for that down the hall. Let's see what he has to say. And I think a lot of places have their own toolboxes. In general, we try to bring more information that's going to be helpful as possible, and that's a generic statement, but that's it's true that it's you work with the resources you have. Honestly, this is where one of the other things, and I will say this to the group because I think it's important, that this is where second opinions are also really helpful. Okay, you can't spend your life getting infinite opinions, but sometimes if you're comfortable with your team and you feel like you're getting good support, absolutely, that's great. That's nothing wrong with that. But most surgeons, and I think honestly, I encourage all of my residents, I encourage all of my patients, frankly, to think very positively about second opinions, because there's nothing to hide. This is a matter of trying to figure out, well, what's best for the person in front of us, and more information is just that. It's more information, and it can be helpful. And frankly, if they find a better fit with a different team, I'm happy for them, and that's great. If they find a better fit with our team, I'm happy that we can help somebody with that. And we just try to keep moving people forward and trying to get them into the best position that we can, whatever that looks like. So for our team, yeah, that means pulling together a lot of people around them. for pain concerns. When it starts to get into more complex medication regimens and things like that, I personally find it very helpful to work with somebody who's specialized in that, whether that's a neurologist focused on headaches, whether that's a pain specialist who has expertise with neuropathic pain. All of those are great resources. Sometimes, and I'll say simple neuropathic pain. That's a whole can of worms. Of course, I've prescribed, neuropathic pain medications in my life. That's part of our job. We absolutely can and should be comfortable doing that, but it's also something that, in general, as it gets with any level of complexity, I try to pull in people who are the best resources. So,
as far as the medication for that more neuropathic pain, especially in the extremities and stuff, is there any new medications being worked on, or is it just kind of the tried and trues?
Mostly the tried and trues, right? So you have I think that's the starting point, and the mainstays of treatment when you're talking about the gabapentin or pregabalin, to try to stay away from trade names. I guess we're probably supposed to at some point. The Neurontin or Lyrica for everybody in the room. As other people call them. We start with the first steps first, right? That's good practice, right? As it gets more complex, this is where I work with the pain specialist. Honestly, there's the field of pain medicine. I know a lot of them, and I don't pretend to be an expert with this, but I don't know of any silver bullet right now. A lot of what we are talking about, especially maybe, and this is a bias from the overlap with our team, but neuromodulation is increasingly valuable. So stimulators, whether it's spinal cord stimulators or epidural stimulators, or for focal neuropathies, which are less relevant in this situation here. But they have a lot more. There are still, beyond that first tier, there is a whole separate tier of how do you. This is the difference. Okay, let me give a really crude example, and maybe I don't even, hopefully not inappropriate, but if you talk about like good bartenders, okay, there's like the level of bartender where you can be comfortable making sure that you're somebody, you hand somebody their simple drink, that you hand them their soda, their beer, whatever it may be. When you're talking about mixing cocktails, I'm not trying to get specific to drug cocktails or things, but trying to understand how different things interact and things. You're going to have different expertise, and this is where somebody, there's a big difference between somebody who really knows what they're doing and not. Okay, anybody can hand somebody their Diet Coke when they ask for it. The understanding how to actually make a good cocktail that's right for the person in front of you is a whole separate skill, and this is levels of things beyond that. So that's where you need to get those good people around you.
Yeah, that's actually a good analogy.
Hopefully,
it works for me personally, but
I don't use it much with my pediatric patients, to be honest.
Not so much for them, but I'm sure there's.
I have no idea what I'm talking about. That's all right.
Close. So I'm gonna get back to some of the questions that came in earlier, because we're kind of talking about nerve pain. So this one ties in. So there was a question: can a syrinx cause intercostal nerve pain similar to like that MS hug?
Yeah, absolutely. No, I like that
actually,
question.
I might ask you to describe what that is, because I don't know if a lot of our population will necessarily know.
No, I really liked that question. I'm glad that you picked that one out. So an MS hug is a neuropathic pain that wraps around the chest, typically the chest wall. I think it can be the abdominal wall too, but more wrapping around bilaterally with typically again, I've used the word dysesthetic. What I mean is that kind of dull, numb pain. Neuropathic, caused by the nerves, pain typically caused centrally by the spinal cord or even the brain. from an abnormal signal. This is really getting into the weeds, but it's how does the pain get generated? There's a lot of theory about this, but essentially your brain is used to seeing certain signals, and when any of those get disrupted at any point, whether it's with a true pain sensor that's sending a positive pain signal, okay, whether it's a loss of that signal, something that's called deafferentation pain, that the pain loss of that going there. It's or centrally, when you lose that ability to transmit those signals, and your brain is seeing different signals than what it's expecting, it's uncomfortable. It's designed to react adversely to that, so that you try to avoid that stimulation. And this is so MS can give you this wrapping sensation, typically caused by a spinal cord dysfunction. Now, a syrinx can give you spinal cord dysfunction. So yes, absolutely, it can be very similar. And honestly, I'm not sure that I can provide a solid way to clinically differentiate that right now. What I would say is that how I would think about that is, this is where, again, bringing people to the table, but starting from a point of information, right? So you want to, if somebody's having new symptoms, you want to reevaluate that with new imaging. It's as simple as it sounds. If somebody came in and they had a history of MS and a syrinx and had new neurologic symptoms, and we looked, and well, sometimes it's as easy as saying, if the syrinx is bigger, that's likely to be the culprit. If they have a new MS plaque, that's likely to be a culprit. If they don't have a diagnosis of MS, but they have symptoms that are concerning for that, absolutely, we want to thoroughly evaluate. This is where even the most detailed algorithms are never going to go into every single possibility. If somebody comes in and they have symptoms that are really painting that type of picture, even if they have a syrinx, and even if they have a Chiari and a syrinx, but they're having something that sounds a lot like MS as we're talking about it, this is where we can't just feed the picture into a computer and go sign somebody up for surgery. We need to recognize that and say, okay, well, this is why this is different, and what do we, based on what we're seeing, this is that probabilistic thinking that we're saying, well, yes, you have a syrinx, but this sounds a whole lot like MS, so I want to work you up for that first, is a totally fair conversation if you need to have that, okay? If somebody has a known diagnosis, then that's a different conversation. Then how do you differentiate those things? Okay, but it was a good, I like that, because it opens the side of the conversation of what is, how do we, it goes back to how do we think and parse out complex medical issues, and that's, again, dives philosophically into things, but it almost too rapidly, but it also is fun to think about.
Yeah. No, and a lot of these things mimic each other, and I know a lot of patients, especially even some on this call, I'm sure, have gone years with different diagnoses that may have not been correct, because they're so similar in presentation. I mean,
absolutely, no, there's a lot of overlap, and that's what's tough. So in general, what we advocate for is trying to be as, working with people that you trust. Okay, find people, a team that you can communicate effectively with, that you feel like you have a good relationship where they're hearing what you're saying. In general, we advocate for some simple things that people can do, and I would say that this is, if I was speaking to a broad group of patients, such as tonight, patients or their advocates, I'd say, trying to keep track as precisely as possible about symptoms, so we can more data is helpful. The more we can understand what you're seeing, feeling, experiencing, the better we might be able to hone some of these decisions and with you. Okay, keeping track of that, I advocate. I tell a lot of my patients to keep a symptom diary, really, so we can get information about these things and be more precise about what we're seeing. Getting more opinions, whether that's from experts in different areas, getting opinions from other teams is always is a good idea if you don't feel like you're being heard or have a good plan around you. That's and it should be really welcomed. I think throughout medicine, frankly, is if I can get on my soapbox here, it's something that if your team really should be saying, hey, second opinions are valid. You know, other people might think about this, or even just use different words to describe something that may click a little bit differently, or tease out a little bit different piece of information, or have a different experience, honestly, at their own institution or personally. That might be relevant here. That's all fair. None of that's off limits. So we, in general, this is the patient advocacy side of things, and it's absolutely important.
Yeah, absolutely.
And that's also where like this, honestly, is very helpful. Sorry to cut you off.
No, I agree. Okay, so a few more questions. So what causes, so I'm not entirely certain what they mean by this because I don't feel it, so I can't explain it as well as they probably could if they were here. But what causes severe burning nerve pain in the head? So I imagine that feels like a burning sensation. I don't know if it's on the skin or I don't know what would cause something like a nerve pain in the actual head. And
Yeah. So if we're talking about a burning nerve pain in the head, there's a couple possibilities of what we could be talking about. There's if you have a syrinx and it goes up to the brainstem, that could be affecting part of the brain that's sending signals to and from the face or even the head as we get into the cervical spine. The back part of the head here is controlled, gets its sensation from some nerves that run through the back, towards the back part of the head, coincidentally. And that actually, you know, so this is where somebody's history is really relevant. So if they've had a posterior fossa decompression, for example, we do see some patients have pain related to the nerve based on even just something as simple as scar tissue around those nerves after surgery, for example. So if it's more posterior and somebody who's had, you know, has a what we call an occipital neuralgia in somebody who's had a posterior fossa decompression, that would be a little bit different than if somebody's having facial pain and has a syrinx that corresponds with that. It's also important to open up the possibility that there are other causes and etiologies for any of these things. So things like a facial pain can be caused by things that aren't the Chiari itself. Somebody may have a Chiari and it's causing problems. There are other nerves that are going to the face, and as you tease out, you'd want to tease out, well, is it ear pain? Is it facial pain? Is it in a distribution of the face? Is it things like that? And there's a lot of reasons for that. In general, the pathways work somewhat similarly to what we talked about, which is that there's direct pain receptors, and then there's also pathways that if they get disrupted, that those can cause different types of pain.
There are three more questions kind of about like symptoms. So I'll start with this one because it's a little out of the other two sort of work together. In Chiari patients, and I guess maybe in syrinx patients with syrinx as well, gastrointestinal problems.
Yeah.
What's that about, and how do you manage those symptoms? I assume it's you try to do surgery on Chiari or the Syringomyelia, but what do you do otherwise?
Yeah, the systemic, this when I was looking at some of the questions, there are a couple questions that kind of focus on some of the systemic symptoms and relationship between GI symptoms or even, and I suspect that the next one you're going to ask about is the variation in symptoms at different time points, whether it's positional or things like that. So talk about that for a second too. So for systemic symptoms, it very well could be related to the spinal cord dysfunction, like we talked about. That's a great mimicker for a lot of things because of the overarching control. It's important to not ignore the relationship that we have between different things. So just as I drew those arrows in general moved left to right, but sometimes there's loops and things that are a syrinx causes something else, or it's all related to some other factor connective tissue disorders is a great example where there's a clear relationship between that and Chiari's, but there's also other problems that you can see related to that, and this is where you really need that multidisciplinary team I find that helpful, I should say. Maybe somebody smarter than me doesn't need that, but as a general rule, it's hard to say exactly what that means, right? So GI symptoms can be variable. If we're talking about abdominal pain, that's one thing. If we're talking about constipation or direct neurologic control and something that sounds or seems more like what we call a neurogenic bowel, that's a whole separate thing. The other question that we have is some of the variability, and this ties in with one of the questions that had to do with variations during a menstrual cycle. And you'll see part of what's tricky about this is that these are not static symptoms. People don't have one symptom in one spot that stays right there and doesn't change. They can change absolutely with changes around them. So it changes with your position. Okay, in general, when we think about position, there was a number of questions that had to do with when I hold my head in a certain position or I sleep in a certain way, I have these symptoms. And this is to try to answer all of those. This is where we try to think about, well, is there a difference in structurally? Is there a difference with your blood flow? Is there a difference physiologically? So we try to think pretty broadly about these things. So when you're sleeping, we might blame a symptom on, well, because my head's in a different position, but is it actually because you're sleeping and you breathe slower and deeper when you're sleeping, and that changes your CSF circulation or changes your blood pressure or something like that? Okay, and that's where a really careful history of teasing out and trying to say, well, and sometimes we do evocative things where we say, you know what, go home and stay awake, but lay, even a little upside down or something like that, right? In turn downward position, what we call. Try to tease some of these things out and try to figure that out, or put somebody into a collar and say, well, if holding your head still, if we take that away, does that change how you're feeling? And again, a lot of that's just trying to tease out, well, what are the individual pieces of information that might give us a little bit more clarity here? As a broad rule, these really tough questions, we try to say, what are the ways that we could try to elicit information that would differentiate different parts of this, or different potentials? We try to put everything on the table, and then we say, how do we sort out something that's structurally different? Sometimes, for example, our MRIs include, we didn't go into super detail about the specific sequences, but we include flexion and extension images to help make sure that we're not missing craniocervical instability. But we can do other things to try to tease these things out too, and vascular causes or physiologic causes or reasons like that. And then this is also so broadly speaking, we try to tease those out. And this is also where working with people who are experts. So if somebody's having GI problems, I'm going to send you to a GI physician who can tell us a little bit more specifically what they're seeing in their field, so we can be as precise as possible.
Okay. You kind of hit on 3 of the other questions that I was going to bring up. So about the lying down and worse in the morning.
Yeah. I've seen some of those, and I think those are great questions because everybody's going to experience things differently. And so I'm trying to put it under a little bit broader umbrella of saying, well, in general, you want to open up a whole list of possibilities and then try to systematically think about this in a way that you can try to separate these things out to get you more clarity of where specifically you are on this map, this broad, really complex, confusing map with all the lines, right? We want to try to put somebody as precise as possible mentally in what is going on, what is their problem, what is this causing, so we can come up with the best recommendations that we can based on that.
So a question came in the chat though. Can syringomyelia cause lack of pain sensation? So from the trauma or injury, similar to an actual trauma, I guess it is actual.
All of this is, the signals are all all a balancing act. This is a big network. Your nervous system is a big network of signals that is coming in and gets filtered, and there's relays, and there's processing of this information and sorting out what's what, and then there's the interpretation of those signals too. It's not a small part of this. But yes, anytime you disrupt that input, anything along that train, you can amplify a pain signal, or you could take away actually your pain processing, and have a lack of pain sensation, where if somebody pokes you with a pin, you wouldn't really feel that. Somebody put something really hot on you, you wouldn't necessarily feel that. And that's absolutely true. And frankly, that's a not uncommon presentation with syringomyelia, specifically based on the location within the spinal cord. I shy away from providing that specific picture because of everything else that I said in the last 90 minutes, which is that this is not a one paragraph description in the textbook. Okay, this is much more complex than that, and everybody's going to be very individualized. We absolutely can see that though, and often do see a loss of pain or temperature sensation with that, but it can be processed as you get into that complex network that is the brain. You get differences in how that's processed and interpreted by the patient, and also that can change over time.
Right. Okay, I'm going to ask this last question, which it was sent in beforehand, but it's very complicated. And the only reason I'm asking is because it also ties in COVID. So this patient is not pediatric, but like a young adult, had COVID and a seizure a couple months ago. And the following MRI ended up with like Chiari, and they've had chronic fatigue, which we know might be related to that COVID, long COVID maybe. But the neurologist said that essentially the Chiari wasn't the problem. So the question really was, could a slight push of that Chiari on the spinal cord that would maybe seem harmless, is that something that might be causing seizures? Or is that something that might be unrelated?
Yeah.
It's so hard to know, and it was a really complicated question, but I'm sorry.
No, I saw that too, and there's a couple talking points here. The first thing I would say is, classically, and where a lot of the stem of this question comes from is talking about, classically, we would say that something that's affecting the cerebellum and the brainstem would not give you a seizure directly as an isolated, here's your problem, here's the presentation pathway. Okay, as this is as we've been talking about, there's other pathways that are with this. So the first thing to address is that there's things that can look a lot like a seizure. So some things that are called cerebellar fits, or people have even talked about things that are called drop attacks being related to Chiari malformations. And this is a bit tricky because we don't understand the full physiology of this. We know that a seizure, I'm sorry, just backing up even a step further, a seizure is an uncontrolled electrical activity along the surface of the cerebrum, along the surface of the top part of the brain, which is separate structurally and physiologically from the cerebellum, the back part of the brain, which is what's herniated down. The bottom part of the cerebellum, the tonsils, are herniated down in a Chiari malformation. So from that straightforward diagram, no, they should not be really related. But at the same time, there are mimickers. There are correlations with things. That's just because this brought it to attention doesn't mean that that's necessarily worth ignoring. If there are other symptoms, for example, sometimes your decisions have to boil down into, well, I don't know if that's related, but we have other reasons. You know, you have a progressive syrinx and a Chiari, we're going to recommend treating that anyway. Let's see if that gets better, right? We do that all the time with headaches, where we say, I don't know if your headaches are going to get better, but we have other reasons why we're going to recommend treating the Chiari anyway. So we'll see what that does, and frankly, your decision making can shortcut through that to really stretch the analogy that I've been beating to death. so third factor, confounding factors are an absolute possibility. Um, especially when we bring in COVID as a mix, one of the things that comes up is uh, a lot. Increasingly, we're thinking of COVID, and I am by no means an expert with this, but I will also say that increasingly we think of COVID not as a primary pulmonary disease, but as actually a vasculitis, a vascular, it causes vascular inflammation, and that can be throughout the body. That's part of where you get the chronic fatigue and long-lasting symptoms and multi-system impact with that. And everybody should go get your vaccine if you're eligible. The uh, uh, the so when we talk about that, it's you can have things that are concurrent but not and related, but or concurrent and not related, and there's a whole pathways that those go through then too. The nutrient side, it's in terms of the blood flow directly, I wouldn't necessarily relate that to the Chiari itself. I would have a little stretch to say that I would say that that's something that I've seen. As you've heard, I wouldn't take anything off the table. I'd want to more fully understand what exactly we're talking about first. And it's a fair question to ask of your own doctors. Well, what exactly, how are these all related or not? And what are how can we explore this and make sure that we're doing everything right for that? And that, can be vascular studies. It should include a detailed MRI in this situation for a lot of reasons, if nothing else, that we should be getting that kind of anyway for a lot of these situations. So, it's and that if that shows something like an unrelated stroke, that happened but even if you tie that to other things like connective tissue disorders, as an easy one to pick on because it can be related to a lot of different areas, for example. So
that was a really good job of answering that. And I know I'll add your disclaimer that we're learning a lot about COVID as we go. So.
Oh yeah, no, absolutely. No, I
yeah.
Yes.
It goes without saying, but I will say
absolutely. No, nobody has a full grasp on all of that yet. It's complex.
Even Syringomyelia, actually.
Right. And frankly, one of the if you look at I'll say the philosophy that I'm advocating in this talk, I think that honestly you can apply that to really any medical condition out there. That it's probably never quite as fully clear. They're very rare that you have a single cause causing a single problem, with a clear answer of what to do about that is going to be the exact same for every patient. That's really not realistic, but how do we try to organize our thoughts and do better is really important.
That's great. And I always like to end with this. So how can people find you? And
sure. Well, if nothing else, I will click to my last slide. So I'm at the University of Wisconsin. This is my primary hospital, the Children's Hospital, but I actually see people physically in this building, but I also do anything. More importantly, for the group, I think email is absolutely fine. Obviously, I'm not going to promise any given specific response time. I do try to get everything back, but I also sometimes waylaid by fighting toddlers and other stuff. So if there is anything I can answer or help clarify from tonight, certainly I really would be eager to.
Awesome. Thank you so much, Dr. Stadler. This was really great.
For having me. I'm really happy to have had a chance, and this has been great and hopefully helpful for those out there and everybody listening at home later. So.
Absolutely. Thank you. Have a good night. Thanks everyone for joining.